Good evening, everybody, and a warm welcome to this ESMO UROwebinar on the management of metastatic kidney cancer. My name is Jens Bethke. I'm from Tübingen in Germany in the southern part, and it's a pleasure in this evening to have dedicated speakers so fast. So I would like to introduce Tom Powles, who is from Bart's Cancer Institute in London. I think Tom is very well known. He's a guideline panel member of the EAU renal cell carcinoma guideline, and a dedicated clinical researcher and basic scientist researcher, beside of being an excellent physician in the treatment of genitourinary cancers. So Professor Powles will give us an overview on the systemic treatment for metastatic clear cell carcinoma versus non-clear cell carcinoma and other types. Then we switch to prognostic models driving systemic and surgical treatments in metastatic renal cell carcinoma according to the EAU guideline. And it's a pleasure that Professor Victor Grünwald from the University of Essen is joining us for this talk. Professor Grünwald also has a long-standing record in genitourinary cancer and especially in renal cell carcinoma. And you're the chair of the genitourinary clinic at your university. And last but not least, I will have a look on how to target the therapy and sequence that, and how is the interplay between the first and the second line treatment. We are very proud that we have sponsoring for this from ASI for this webinar this evening. So now I switch over to Professor Powles for his talk on the first line treatment in renal cell carcinoma.
Firstly, thank you for inviting me. Secondly, Jens, thank you for doing my slides for me. I know I should be doing this, but I've had some technical issues. So I just haven't managed to get my computer working. But Jens is doing my slides for me, so I've got perhaps the most qualified slide mover in history, for which I'm very grateful.
Tom, it's a pleasure, of course. Yeah.
Jens, so let's move on, if we can, to the next slide, and that's the next slide, if I can. So look, the title of my talk was a bit unusual as well, and it talked about translating or comparing clear cell and non-clear cell disease. And I'm going to talk about clear cell first, and then I'm going to talk about non-clear cell. Clear cell's been really fast. I don't think we should be comparing them. And why not? Well, they're not the same. You know, it's like comparing a duck and a tree. And because clear cell disease is driven actually quite strongly by a VHL VEGF axis. It's a tumor which is associated with actually quite a unique immune infiltrate, and it has a low tumor mutational burden, and it's characterized by high expression of Treg cells. So it's actually like melanoma. It's a cancer, clear cell renal cancer. It's out on its own, and so clear cell renal cancer and papillary renal cancer have got the same in common as clear cell kidney cancer and breast cancer. And so you might say, why would one be treating these with the same group? And the answer to that is because they are anatomically in the same organ. And that's obviously a bit of an issue. So let's start with clear cell renal cancer and the story so far. And the story so far essentially is that we've developed PD-1 based therapy. So patients with good, intermediate and porous disease essentially are getting pembrolizumab and nivolumab. The pembrolizumab can be given with two drugs, axitinib or lenvatinib. And indeed, the nivolumab can be given with two drugs, cabozantinib or ipilimumab. The ipilimumab is a CTLA-4 inhibitor, ipi-nivo, people call it, and that's for intermediate and porous disease. The PD-1 based therapies, len-pen, cabo-nivo, axi-pembro, for good, intermediate or porous disease. And here in light grey, we've got sunitinib or pazopanib for good risk disease. The most recent data we have suggests that sunitinib and pazopanib, from a survival perspective, perform about the same as the VEGF TKI IO combinations. The response rate's lower. We haven't yet got the long-term data, Some people say until we have the long-term data, people should be getting the combination. I'm actually bought into that camp to some extent. That doesn't mean no one should have sunitinib or pazopanib. There are clearly some patients who can't have immune therapy. And on top of that, there are patients who don't want to have immune therapy, or indeed, there are some patients, perhaps the frail or those with comorbidities, who might just want oral therapy. And I understand that principle. So what do we have? We have three ducklings: cabo-nivo, len-pen, axi-pembrolizumab. The VEGF-TKI IO combinations, more similarities than differences, given broadly for advanced kidney cancer. What about CTLA-4 PD-1? Well, less good than the VEGF PD-1s at initial control of disease. Response rates 40% rather than 60 or 70%. But there are some advantages as well. You don't have to give the long-term VEGF TKI for years and years. And that's a real problem for the VEGF TKI IO combinations. And actually, it has the longest follow-up data. And it looks like there are durable remissions associated with CTLA-4 PD-1 ipi-nivo therapy. So in one slide, I hope I've given you where we currently are in advanced clear cell kidney cancer. Let's move to the next slide, Jens. So the next issue is around triplet therapy. And I wanted to talk about triplet therapy. This is a new approach. I've talked about doublet therapy. This is cabo, ipi-nivo. Why would triplet therapy potentially be better than doublet therapy? Well, as I said before, ipi-nivo, not great at getting initial control. If we give the triplet up front, do we increase that response rate from 40% to 70%? Do we increase the PFS from 10 months to 15 months? And do we improve survival? Those are the key questions associated with this trial. Next slide, please. And you can see from here, the progression-free survival is statistically significant, with a 25% reduction in the chance of relapse. You can see here that the median has not yet been reached. Having said that, it looks like it's going to come out somewhere in the region of 15 months. You can see it plateauing at 0.5. So somewhere between 15 and 18 months, we can expect PFS for cabo ipi-nivo. And that's a positive randomized phase 3. That's encouraging. Is it clearly better than cabo-nivo? Well, we would have expected 15 months from cabo-nivo, so not necessarily. Next slide, please. The response rate was actually a bit disappointing for the triplet at the bottom. You can see the responses here for the triplet. Oh, sorry, for the top, the orange is the triplet. The response rate in the region of 50% rather than 60 or 70%. And so I think people were somewhat disappointed by this response rate. And I think that's reasonable. So the response was underwhelming, but the PFS was encouraging. We haven't yet seen any overall survival data. And so the overall efficacy signal, I think, is mixed. It's achieved its goal, but without survival, it's difficult to see how this changes practice in unselected patients. Let's move to the next slide. The key to this is it did appear more tricky to give the triplet than the doublet. And it appears that by giving 3 therapies, we may be compromising our ability to give them well. Because you can see here, in terms of doses of ipi received, it's 4 doses, 60 versus 70%. You can see here discontinuations of any study treatment, 45 versus 24%. And actually, when you look at grade 3 or 4 adverse events, it's 20% higher for the triplet than the doublet. There were some subtleties of this trial, could have been done differently. It was during a pandemic, of course. There was a placebo in the trial, and there was more transaminitis than we were expecting. But I think overall, it's fair enough to say that as things currently stand, this is a triplet that was challenging to give. And the results from efficacy, I think we need to wait for overall survival before it changes that original story which I told. Next slide, please. One of the most intriguing things about this study was it showed that in the poorest patients, the benefit was less marked than the intermediate risk patients. Now, when we started this trial, many people believed that actually it was the poorest patients that we'd get best control. And the poorest patients were those we needed to get control. And indeed, it was the poorest patients that we worry about that progress quickly. So it was surprising to see the benefit confined mainly to the intermediate risk patients. Let's move to the next slide. And the next slide. And what we can see on the next, in the bars in the middle, is the biology of the disease. And in purple and red are VEGF-driven tumors on RNA analysis. And you can see in blue, orange, and green the immune therapy-driven components. And as we go from favorable to intermediate to poor, you can see fewer and fewer VEGF-driven tumors. And that's probably why the cabozantinib is not making a big difference to ipi/nivo in the poorest tumors, because it's not driven by VEGF-targeted therapy. This creates a bit of a conundrum, because it suggests to us, as the cartoon on the far right shows, that VEGF-targeted therapy is mainly beneficial in good risk patients, whereas in poor risk therapy, it's mainly driven by immune therapy. And it may only be the middle group that currently needs the triplet. Let's wait and see what the survival signal shows. Let's move to the next slide. Ipi/nivo has not had a fantastic year. This is the adjuvant ipi/nivo trial, which failed to show a survival or PFS benefit compared to placebo, where pembrolizumab did show that benefit. This may have been down to the duration of therapy, the sequencing of the drugs, or indeed the toxicity of the triplet of ipi/nivo. Nevertheless, it's worthwhile saying that these long-term durable benefits of the ipilimumab are beginning, in my opinion, to be questioned. That doesn't mean ipi/nivo is not a great regime, but it doesn't mean to me, as it currently stands, it is the only standard. I genuinely think that VEGF-TKI, PD-1 combinations are an attractive alternative. Next slide, please. So let's move to the second component of this talk, completely different. And here we look at papillary renal cancer, which has recently been reclassified by the WHO. And in fact, there are a number of different classifications, which is complicated to follow. There are also chromophobe cancers. And I think I'd like to come out immediately and say it doesn't look like VEGF-targeted therapy works particularly well in chromophobe cancers. I'm going to focus my talk mainly on papillary cancers. We know less about the other cancers. The one exception is sarcomatoid tumors. And please, please, please give immune therapy to sarcomatoid patients who with advanced disease. It's transformative for that group of patients, and it's absolutely crucial. So the only takeaway message, if there's only one from today, please make sure those sarcomatoid patients are getting immune therapy. Let's move to the next slide. These are the current ESMO guidelines for papillary renal cancer. So this doesn't include those other rarer tumor groups. I'm going to focus mainly on papillary cancer. It is the most common after all. First-line therapy, the preferred therapy with level 2B evidence is cabozantinib. Alternatives are sunitinib, pembrolizumab, and savolitinib in MET-altered tumors. And then second-line therapy is really whatever you choose that you haven't used already. You'll note there that there are no immune-immune combinations or immune VEGF combinations. I think there needs to be a discussion around those combinations, and I think it is important, and I'm going to come to that in a second. Next slide, please. So this is the first group of studies comparing sunitinib over everolimus, and this justifies sunitinib. Next study, please. And you can see here in sunitinib potentially outperforming everolimus, but not by miles. And the progression-free survival is pretty short, and the overall survival is disappointing for both. So about 6-month PFS, OS tends to be under a year for sunitinib. And those are the benchmarks I'd like you to remember. So 6 months and 12 months for advanced papillary renal cancer. Next slide, please. These are other studies also looking at comparison of sunitinib and everolimus. And you can see from these trials, there is some consistency. And I think it's reasonable to say that everolimus doesn't really have activity here. And I think it's also reasonable to say that sunitinib outperforms this. But there's no significant trial where you can definitively say sunitinib is the standard of care. Nevertheless, it's been widely adopted as such. And therefore, if you move to the next slide, this trial, which looks at 4 different drugs in papillary renal cancer with 180 patients, comparing sunitinib with 3 other agents. Now, 2 of these drugs, crizotinib and savolitinib, were both stopped early, but cabozantinib was continued. Let's move to the next slide. And here we can see in dark blue PFS, cabozantinib outperforming dark green sunitinib, and that's a significant benefit. So this is a positive trial published in the Lancet, cabozantinib with a PFS advantage. And because the numbers are relatively modest, next slide, please. Sorry, could you go back one? I apologize. Because the numbers are relatively modest, we never got significant overall survival. It wasn't a study designed to get overall survival. The overall survival for cabozantinib did show a numerical increase compared to sunitinib. And for that reason, this is the justification for cabozantinib getting a 2B rather than a 3B recommendation for sunitinib and other agents. So this is currently the standard of care. Next slide, please. The savolitinib is a MET inhibitor. Papillary renal cancer has a significant portion, probably 40% of patients with MET-driven tumours. And indeed, one can measure MET using DNA analysis. Foundation is a way of doing that. Indeed, you can even measure MET on circulating biomarkers. MET is a driver through a number of signal transduction pathways. And savolitinib, as a single agent, has been tested against sunitinib in papillary renal cancer. Next slide, please. This is a randomized trial. You'll see the numbers are super small, but look on the right-hand side, there's a survival signal for in MET-driven tumors, about 40% of papillary renal cancer. There appears to be an advantage of savolitinib over sunitinib, which I think is exciting. And this is relevant because while this trial was stopped early, we have moved on with the development of savolitinib in this disease. Next slide, please. This is savolitinib and durvalumab together. Durvalumab is a PD-L1 inhibitor, and this is a response rate of the combination in MET-driven tumors is 53%. Now remember, the response rate for sunitinib is only 5% and cabozantinib only 20%. Here we've got 53% in MET-driven tumors. So this has led to a 3-arm randomized phase 3 trial. And please, if you're keen to take part in personalized medicine, this trial's open in 120 centers around the world. We're trying to recruit. Sunitinib is a control arm. It's a historical control arm. As you know, it's not been beaten from overall survival. We don't know what cabozantinib is like in this disease, in this subset of patients. I think it's a reasonable control arm. I think cabozantinib, you might say, is a preferable control arm. Obviously, it has some MET activity, making this trial more confusing. If that was the control arm, I think it's justified as a control. This is a really important personalized therapy study. Please participate if you'd like to. Next slide, please. And there's also this terrific German study. It's a randomized study of ipi-nivo versus sunitinib. We took part in this study. I think it's a really important study, really defining the role of immune therapy. And why we do need to do this? And the reason why, is because I'm going to show you a series of single agent studies looking at immune therapy now. And my concern around these single arm trials is without randomization, it's difficult to know exactly what's going on. Next slide, please. And next slide. So this is Keynote 427. This is the non-clear cell papillary cohort. So this is pembrolizumab alone in first-line disease, 120 patients. Next slide. And you can see here, 160 patients. And you can see here, most of them 70% papillary renal cancer. There was some chromophobia as well and some unclassified. Next slide. And you can see response rates actually are modest. So you can see response rates of, a greater than 30 reduction in the tumor lesions of about 27%. So again, actually quite competitive when you compare to cabozantinib or certainly sunitinib. Next slide, please. And the slide after that. The median progression-free survival is short at only 4 months. Cabozantinib, a longer progression-free survival, similar response rates. And so it's hard on this single-arm trial without randomization, with a short PFS and modest response rates, to give anything more than a 3B recommendation. And I think that's a shame because we don't know how active this is, but certainly the survival signal looks great. And I think that is relevant. Next slide, please. The next story is we've actually looked at cabo-nivo and len-pen in 50 and 150 patients respectively. We've seen response rates of about 50%, indeed 53% in papillary renal cancer for len-pen. Those results look outstanding. Much lower in the chromophobe. Difficult to tell, again, from a PFS perspective, it was about 12 months. You might say that also looks outstanding. I think it does, but with no randomization, it's difficult to tell exactly what's going on. I think these should, in my opinion, make it into the recommendations from the European perspective. I think they are attractive alternatives to cabozantinib as a single agent. But are they the standard of care? I think without randomization, the answer is no, in my opinion. Next slide, please. So where are we? We've used the same approach in non-clear cell and clear cell. I think that's disappointing. Of all the data I've showed you today, I think the savolitinib data is the most promising because it's personalized and it's specific for this tumor group. We're not pursuing the biology, and that disappoints me. And indeed, if breast cancer doctors were looking after papillary cancer, had they pursued the same approach as the kidney cancer doctors, they'd probably be giving these patients anti-estrogen therapy if you use the same logic. So clearly that's a flawed approach. We need to pursue the biology in papillary renal cancer. Single agent VEGF TKIs are the standard of care, but there are alternatives, and particularly the VEGF TKI PD-1 single arm data looks encouraging, although it's not randomized. The MET PD-1 SIMETA trial, please support that study. Wouldn't it be nice to have randomized data supporting the use of combination therapy using a personalized approach? There's no role for adjuvant pembrolizumab in this setting at the moment. Thank you very much for your attention. And Jens, thanks again for helping me with the slides. I'm really grateful.
Well, thanks a lot, Tom, for presenting and giving this deep insight into the systemic treatment. So we really appreciate that. There was one question from the chat, and well, it was addressing the triplet therapy. We know that it's not filed anywhere around the world currently, the COSMIC data, but let's assume, well, there are other trials ongoing, and let's assume it's available. What would be next after the triplet therapy? That's the question being addressed in the chat.
Yeah, so this is a great question. Now, it depends on where the patient is when their cancers progress. Many patients on the triplet aren't on the triplet when they progress. So many of them will be on cabo-nivo because they'll have had the IPI, and many of them will maybe not on even cabo and nivo because they may have run into immune-related toxicity or VEGF targeted therapy toxicity. One of our challenges was it was hard to give the triplet, speaking frankly. And so it's possible that the patients won't have completed that treatment, and therefore there is a personalized type approach to that. Having said that, for the vast majority of patients, irrespective of the detail of how the patients got there with progression, sequencing VEGF targeted therapy is the standard approach. And the standard where I come from, I would probably try axitinib. I would have no problem if you said I wanted to give lenvatinib and everolimus. I wouldn't have a problem with that. I wouldn't have a problem if you said you wanted to give sunitinib, to be honest. I think that it's licensed in the setting and it's a broad spectrum VEGF TKI. So any VEGF TKI you haven't used already, I think is attractive, and that would be my preference, and certainly above len-everolimus, in my opinion, although other people I know feel differently and are more impressed with the len-everolimus data. What about continuing immune checkpoint inhibition? Well, I think without data, it's really difficult. I'm excited by the results of CONTACT-3, which is cabo-atezo versus cabo alone, or ENTIVO-3, which is tivozanib with or without pembrolizumab, nivolumab in this setting, to work out if there is a role for continuing immune checkpoint inhibition. So at the moment, I suspect just VEGF TKI and use one you've not used previously.
I think it's a long story, and we could keep for hours how to drive treatment decision in this metastatic setting, also addressing what to do after adjuvant failure, or should we use combinations, only combinations in non-clear cell. But I think in the matter of time, I thank you again very much for your talk, Tom. And I think we switch on to Professor Grünwald from Essen. And Victor, it's my pleasure to introduce you for your talk, Prognostic Models Driving the Systemic and Surgical Treatments in Metastatic Renal Cell Carcinoma. Well, it's of course according to the EAU guidelines.
And so thank you, Jens. And yeah, I think it's great to have the opportunity to talk to you tonight on this topic. And I think it's an exciting group, and I really appreciate the opportunity. So my task is really to speak about prognostic models and how do we use them in clinic. And it's not only medical, but it's also about surgery. So these are my conflicts of interests. And basically, I would like to start very basic. I mean, so what are the parameters that really inform prognosis in localized RCC, and why is that important? I think it's because we have the novelty of adjuvant treatment, which is for the first time in RCC, and now we have to really make up our mind. You know, how do we approach patients, and how do we counsel, and how strong is the recommendation? And that is some sort of associated with the risk of recurrence. So we've heard from Tom that kidney cancer is not one disease. It's many diseases, different entities, and they're all different. And I mean, we just lag behind a bit with our treatment development. But I think, I mean, this is a very nice cartoon that gives you a good example that depending on where the cancer comes from, so where it originates, it will have distinct morphologies, but it also may have different biological behavior. And how do we perform in clinic, basically? And I think what we do is that, of course, histology is of value, and the reason why is depicted here, and that's actually from the EAU guidelines. So looking into the type, so histomorphological type of kidney cancer, it will tell you that depending on the type of histology, you have a certain association with clinical outcome, with clear cell carcinoma having the worst cancer-specific survival at 10 years, which is about 62% overall. And that is some sort of related not only to the histology, but also to the extent of disease. And I think you can figure, looking into the table for the clear cell subtype, you may see that there's a higher percentage rate of patients having synchronic metastatic disease or larger tumors at time of diagnosis for clear cell carcinoma, and that is a driver also for prognosis. It's not only the histology, but it's informative. And then having this second analysis, looking into tumor size. I mean, does tumor size predict prognosis? Well, I mean, looking into the analysis from the EAU guideline, I think is very nicely referenced here that the larger the tumor, the higher the risk for recurrence and death. And especially that is true for those that have lymph node involvement or metastatic disease, of course. So that's why we have this sort of recommendation in the EAU guidelines that TNM staging, you know, tumor size, grading, but also the subtype of RCC do really inform on prognosis, and therefore these are important prognosticators. So what do we do in clinic? Well, when we go to the clinic, I mean, there's just a whole bunch of different prognostic scores or nomograms in order to predict outcome. And I've listed those that are referenced in the EAU guideline. And I think, to make a long story short, I mean, any of those can be used in order to categorize patients into prognostic groups, and that is applicable for localized disease only, of course. So I think, I mean, starting from the left, I mean, something you have to keep in mind that not all of those cohorts that have been investigated are one single group of cancers. So I mean, like UISS investigated all types of renal cell carcinoma. And I think when it comes down to the types of cancers integrated into those scoring systems, there is a bit of variation. Basically, most of them, of course, assess size of the tumor, lymph node involvement, and grading. And then there are some additional factors that are highlighted here by putting them into bold numbers or letters. And some of them may involve performance status, such as UISS, or the dependency on necrosis, such as in the original Leibovitz score. And then there are others that focus on tumor thrombosis, or others that look into the age group of patients. However you do it, I think they're all valid, and they have their pros and cons and their weaknesses, and can be used. So what about molecular subgroups? I think that's something that is more and more becoming a theme in GU cancers. And it's part of our clinical reality in prostate cancer. It is not so well established in urothelial cancer, and is so far it is not well informative in kidney cancer. However, when you look into the evidence, I mean, there is a number of patients that have sufficient amount of mutations that can be diagnosed or in clear cell or other entities of kidney cancer. And they also inform on prognosis and type of recurrence. And that is depicted here on the right-hand side, where you do see that whether, if you have a BEB1 mutation or SETD2 mutation, I mean, these are the ones that are at a higher risk of recurrence. Fortunate enough, it's a smaller group of patients. The question is really, is this ready for prime time? And I think, I mean, it's very, very well worded and framed in the EAU guideline, suggesting that it's not actually. So therefore, you have some recommendations for the use of prognostic scores or nomograms for localized disease. And of course, the TNM system is quite strong. Then there is the WHO ISUP grading system that should be applied to renal cell carcinoma subtypes. And prognostic models, they vary and they should be used. I mean, but there's not a specific model that should be used. It could be used any of those that are have been highlighted here. And the next point is really not to use the molecular markers in order to inform on prognosis, because we are not there yet. We do need more studies that have a better prognostic impact, or identify the prognostic impact in order to make it into the clinic. And I think that's pretty much it, what I wanted to talk about for localized kidney cancer. So the question is then, what about metastatic kidney cancer? And you've heard that we do have a current development to more intense therapies. And is it important to really score our patients and categorize our patients according to risk scores? And which of those parameters can be used? And I think it all started really early on in the 2000s or 2002, when Bob Motzer really had his first analysis on prognosticators in kidney cancer, and that specific population of patients is really coming from the cytokine era, and he looked into drivers for prognosis in those patients. And at the time being, those factors have been the time to medical treatment, which is within 1 year of initial diagnosis. It's the occurrence of hypercalcemia, anemia, low performance status, and high LDH. I mean, these are the prognosticators that have been used in the original score, but it came at a time point when we used only cytokine-based therapies. So what happened next is really that people tried to advance this type of score, and it took a while until we had a change in the treatment landscape when TKI therapies have been introduced, actually, and were part of our treatment reality. And this is when really Danny Heng was able to establish a score that is now called the IMDC risk score, which is, I would say, the predominant score to be used in metastatic kidney cancer. So what is so different about that score? I mean, it kind of builds on already known prognostic factors that we have been using in the MSKCC score, but it deleted the LDH because it was not significant in the association and not strong enough in this larger group of patients, in this TKI cohort of patients. But it integrated two additional factors that are identified in blood tests, and that's the thrombocytopenia and it's the neutrophilia. So very easy to assess in order to improve that original score and advance it to the new IMDC score that has a bit better prognostication or better predictability, and it has been developed in a TKI contemporary cohort of patients. And then the most recent advancement, I think, is this important work that Bob Matza also presented and published, and he and his co-authors, they looked into molecular signatures, and they have been classified in order to their phenotypes, and they are identified basically in angiogenic or pro-angiogenic and more immunogenic or inflammatory signatures. And something that we have learned by looking into the IMDC risk score that gives you this nice separation of curves when it comes to the prognosis of patients and grouping patients into favorable, intermediate, or poor risk. That is something that is associated with a typical behavior, biological behavior of the tumor type. So by using good risk or favorable risk, this is the subgroup of patients that benefits most from a TKI or VEGF inhibition. And by looking into these signature analysis, you may recognize that whatever is violet and red, these are the ones, these are the subgroups of the angiogenic signatures and that are TKI sensitive, and they enrich for response to sunitinib. So what it tells you is that, you know, by using these very simple clinical parameters, you enrich for TKI sensitivity in this prognostic model. But something you also see is that there is always a proportion of patients that respond to immunoagents. They have this T effector proliferative signature, RNA signature, and that is something that occurs in any risk category, but it enriches in patients that have more than just one or more risk factors, actually. So in poor risk patients, you have the highest chance of immunogenic tumors. And something that Tom also alluded to is the sarcomatoid feature of kidney cancers. So one of the questions is, it has become, with the advent of immunoagent, sarcomatoid RCC has become one of the go-to subtypes. And the question is it really a subtype? And according to the WHO, it is not. I mean, it's first of all, it's not a standalone entity, and it's not a sarcoma. And I think that's quite important information for your everyday clinic, actually. At the end of the day, it represents a de-differentiation of an epithelial tumor type, which is in that case RCC, but it may occur in many other cancers as well. And this is an example how histopathology may look like. So why is it important? And I think when you look into the very same analysis, looking for angiogenic and immunogenic drivers, what you see is that in sarcomatoid RCC, indicated here with SRCC, you have a higher proportion of patients that have inflammatory tumors, and they are PD-L1 positive. They tend to be more driven by PD-L1, and they're highly inflamed tumors, and therefore immunotherapy seems to be a better choice in these patients, as indicated here on the left-hand side by this progression-free survival curve, actually. So sarcomatoid clear cell RCC are predominantly inflammatory tumors, and I think that's something you have to keep in mind. So in conclusion, I think RCC entities and the extent of disease inform on prognosis. I think that's not a surprise. You can use different prognostic models in the localized disease. I think that's something that is quite clear. And then in the metastatic setting, IMDC and MSKCC scores are the ones that are being used predominantly in order to predict outcomes in metastatic RCCs. So with that, I would like to thank you and give you a brief impression from the Essen region, which is very industrial. So thank you for your attention.
Yeah, thanks a lot, Professor Grunwald. Thank you, Victor, for giving us this deep insight. We will have a short discussion afterwards, and I think we just switch on to the last talk, which will be by my person. So the topic is how targeted therapy and immune checkpoint inhibitors can interplay within the first and the second line treatment in metastatic renal cell carcinoma. My disclosures. So what are the objectives for this talk? So I think we should understand the therapeutic options after progression on TKI and IO combinations, and after IO and IO combinations, and to define a little bit the treatment sequencing in clear cell metastatic renal cell carcinoma. Well, what about sequencing? And should we think of sequencing before we start first-line treatment? I think, Victor, you outline all biomarkers, what is currently available, but to be honest, we have no clear biomarker in RCC to guide treatment and to say, well, this is a patient of poor risk because it's such a heterogeneous disease. And we should, I think, remember that half of the patients do not actually receive second-line treatment, which, well, I think first-line treatment is tremendously important for our patients if we consider sequencing. Well, so what are the data? So if we consider first-line treatment of tyrosine kinase inhibitors as a monotherapy, you all know there's a bunch of trials which are available after TKI failure in the first-line setting. So we have strong recommendations. We have different trials of axitinib, of cabozantinib, of temozolomide, sorafenib, of nivolumab, also of combinations of lenvatinib and everolimus with a PFS advantage. And some of these trials also demonstrated an overall survival difference between the treatment arms, especially the METEOR trial of cabozantinib comparing everolimus in the second-line setting, but also nivolumab versus everolimus also in the second-line setting. But this is always that you had TKI as a monotherapy. So what in our days if we have a pre-treated patients post-IO after ipi-nivo or after TKI-IO combinations? And well, it's like walking through a desert. We do not have any science. We do not know what to do. There's no really prospective data based on a phase 3 setting. Well, what are the recommendations then by the EAU guideline? Well, recommendations are well established after the TKI monotherapy with nivolumab and cabozantinib on a 1B level of evidence. But after prior IO, the current standard of care as a level of evidence 4 is any VEGF-targeted therapy that has not been previously used in any combinations of the IO. Well, I think this will change in the future, and there are trials out there which will probably drive our treatment directions in the future. But what is the data which is available right now, and what are potential, let's say, opinions or thoughts? What could we do as second-line treatment strategies? So first of all, we could think, well, let's go for a VEGF-targeted monotherapy in the second-line setting. We could have the options of using combination strategies. What's data for? And well, what about IO salvage strategy? Can we salvage patients by adding another checkpoint inhibitor? And last but not least, new trials and new agents. What is ongoing? So if we have a look at the VEGF-targeted monotherapy, yes, there are some prospective trials for this TKI monotherapy post-IO TKI failure with axitinib, pazopanib, and sunitinib. Well, what do we learn from these trials? Yes, there is activity for TKI monotherapy in that setting. PFS is less long as we know from the first-line setting. Objective response, yes, it's given a little bit lower than what is observed in the first-line setting. But to summarize that, you know, TKI monotherapy is working after an IO TKI failure in that setting, and this is data from prospective phase 2 trials. There's a lot of bunch of retrospective analysis or subgroups from prospective trials with the different TKIs or also combinations, lenvatinib, everolimus, or tivozanib, the TIVO3 trial, which Tom Pauls also mentioned earlier. They have the TKIs as a monotherapy. And again, the signal is the PFS is a little bit shorter. We get responses, but maybe we take it home, use a TKI which has not been previously used in the first-line combination. So what about combinatory trials, which are ongoing or have been ongoing? So we have results from the phase 2 setting. Here, for the combination of lenvatinib pembrolizumab, the Keynote 148, it's len and 20 milligrams, pembrolizumab every 3 weeks. And the patients which have been treated in this trial were patients who had an ipi/nivo in the first-line setting or TKI combination in the first-line setting. So what do we observe? It's a 100-patient cohort. First of all, the median PFS was about 12 months in this setting. And we got if you have a look at the Kaplan-Meier results, the Kaplan-Meier curve for the overall survival, I think, it gives us a strong signal. And what about responses? So response rate, objective response was about 55% after a PD-1-based combination, and after prior PD-1 therapy, and it was about 59% after TKIs and 47% after ipi/nivo. So once again, it seems that the combination in such a setting increases our activity and response rate for a combination after pre-treated patients. Well, we have also data for the combination of lenvatinib and everolimus in that setting, in the second-line setting, the study 218. There was a small subgroup within this trial with patients who have been IO pre-treated. And let's go to these results. Once again, a median PFS around about 12 months with these combinations in that respective setting. Median OS was about 17 to 18 months here. Well, let's move on to salvage IO therapy. What is the data? You know, there are different trials which have been presented, the Titan trial, the Omnivore, the Fraction trial. And if you summarize these trials a little bit, it's a strategy of adding ipilimumab to a PD-1-based therapy. Well, I think in general, the response rates are rather low, which could be increased after IO failure, after PD-1, PD-L1 failure in that setting. About 10% of patients who get a response in that setting. If we have a closer look at the Titan RCC trial, so it's a salvage EP trial in nivolumab non-responders. So this trial has been the first and the second-line setting. More than 100 patients have been treated. So patients who had no response on nivolumab monotherapy within the first 16 weeks could have additionally added ipilimumab in that setting. And what are the responses here? So best responses in that setting were about 12%, 13% of patients having an additional partial response after only stable disease or progressing on the nivolumab. So in general, there's a 10% of margin which we take home for such a salvage strategy in that setting. What are ongoing trials after IO failure? And I think this is of importance. We have big phase 3 trials, the already mentioned CONTACT-03 trial, a trial of cabozantinib in addition with atezolizumab, the PD-L1 inhibitor, a 1-to-1 randomized to cabozantinib in that second-line setting. But you also have the LIGHT-SPARK11 trial ongoing, which is a trial of belzutifan, the HIF-2 alpha inhibitor in combination with lenvatinib compared to 1-to-1 compared to cabozantinib in that setting. So we expect phase 3 data in that setting to guide our treatment decision. Probably we are leaving the desert if these trials will be positive. Well, now, another trial, and we're talking about monotherapy, and we talked about limited prospective data. Here we have the CABO-POINT trial, which uses cabozantinib as a monotherapy after ipi/nivo failure in the first-line setting, then followed by cabozantinib, or after TKI/IO failure in the first-line setting, then followed by cabozantinib. So this trial is already closed, so we expect the data to be presented. Now, we move on how to define the treatment sequencing. And we know that there has been a lot of arousal of the PFS2 during the last month and the last congresses. What exactly is PFS2? I think we all know progression-free survival in the first-line setting. So PFS2 is defined as the time from the first drug or combination until progression and the second-line drug until the next progression. So this is PFS2. And from the first-line trials, we have the PFS1 data, or the progression-free survival. We have the overall survival data, but sometimes we have a gap in between, especially if overall survival is not really so mature in some prognostic IMDC risk groups. So how can we fill this gap and get some more information? So this is where the PFS2 steps in. And just to give you one slide for that, the PFS2 data from the cleared trial, from the combination lenvatinib pembrolizumab. Well, yes, we know that starting with the combination, then followed by a second-line agent, is superior in terms of starting with the TKI monotherapy with the sunitinib, then followed by a second-line IO agent or a second-line TKI. The same data is also available and positive for the Axi-Pembro combination, but also for the Cabo-Nivo combination. So now let's summarize our topics. So first of all, please consider that not all patients achieve the second-line treatment. Half of the patients will not be eligible for second-line treatment options. We know that there is TKI activity as a monotherapy in previously IO pre-treated patients. So for the second line after Ipi/Nivo or after TKI-IO, there's currently no phase 3 data available. We have available subgroup and retrospective data for this setting, and we get the feeling that the TKI-IO combination based on the phase 2 KEYNOTE-146 has a median PFS of 12 months. We have the activity, the efficacy of the TKI monotherapy around about 7 to 12 months in that setting. But in general, TKI monotherapy activity in that second line setting in PD-L1 pre-treated patients is lower in that setting. While CTLA-4 salvage strategy seems to have a limited additional value. And please remember, phase 3 trials post-TKI-IO and IOI are ongoing. And if you have the chance, please recruit patients into these trials. So thanks a lot for your attention for this talk. And I think we can go on to the Q&A session right now.
Yeah,
so Victor,
it's a very good summary. I mean, because you're the one leading it, so you have to have some echo. So.
No, yeah, well, I think we can move, Victor, to the questions, and well, maybe I'm just first to address you on the molecular signatures. So, I mean, if you would have a dream, where would you like to have your prognostic tool? Where do you see the clinical gap? Is it in the metastatic setting, or is it in the locally advanced adjuvant setting?
Yeah, I agree, and so I think right now, I mean, we're focused on the development and kidney cancer and metastatic setting, but I think, I mean, it's much more important in the localized disease, and whom do we really treat with adjuvant treatment? And I think we're not so good in the prediction right now, and we don't have a clear-cut idea on really how to select patients for the adjuvant setting.
And now, you know, if we dream a little bit, I mean, everybody's saying, well, TNM is nice, we have clinical factors, we have scores, but everybody says, well, we need molecular markers, we need molecular scores. What do you think? What would be of importance for you? Is it ctDNA? Is it tumor biopsy? What do you think is a far advanced tool or approach?
Well, of course, liquid biopsy is great. You know, it really is a bit easier to assess, and it gives you a better overview of the heterogeneity of the tumor. But you know, we also have to be realistic. In kidney cancer, that may not be the optimal, you know, the optimal choice. At least not with the current development. I think is more complicated in kidney cancer because not every kidney cancer is really shedding enough circulating tumor cells into the bloodstream in order to be detected. I think that's one of the issues, but I think that's technical. I think that can be solved in the future, and probably, you know, we have to, for right now, I think we have to better understand, you know, what is the type of blood test that you would like to have. But I totally agree, blood testing is great, and I would really appreciate to have a blood test in order to predict prognosis in my patients. So I don't know if you had a chance to look into the Q&A questions, because I answered already 2 when you were talking.
Perfect. Thank you. Yeah, please go on.
And there's one question for medullary RCC. So now really talking about a small subset of patients, you know, so I don't know how you address this. I mean, what do you do, Jens? I mean, medullary carcinoma, renal medullary carcinoma?
I think we heard a lot about the non-clear cell entities. I think, first of all, it's a rare tumor. Of course, I would like to have a secondary opinion by a pathologist if it's really medullary carcinoma, just to confirm that. And I think we learned a lot that combinations in general have a higher activity if compared to monotherapies. So I probably would drive my treatment decision to a IO-based combination in that setting.
Yeah, you see, I mean, so my priming is a bit different because I'm coming from the sarcoma field, and there's a similarity that RMC shares with other tumors that's rhabdoid tumors, and it's something that occurs in young patients, and that also applies to our RMC patients, and it has the same molecular mechanism and defect which you see going through ENI1, and it's I would use chemo in those patients, I must say. So my experience with RMC patients, they're not responding well to immunotherapy, and the chemotherapy for me is my preference of choice, and I follow the EU rhabdoid tumor registry in those patients, and I think it's the best match for me in terms of this type of tumors and type of therapy. It's very intensive therapy, and it's really sarcoma. It should be done by sarcoma specialist. So I think it's very difficult to answer the type of question because there's no right or wrong. There's just opinions on how to treat those patients, I think. But for me, it's chemo, definitely.
Well, and we learned also that the sarcomatoid tumors should be treated with an IO-based combination. So I think we learned that from the first talk. Well, Victor, looking at the time of this webinar, so I think 1 hour passed by in a very, very fast fashion. It's like, you know, being here close to Stuttgart with all the Porsches on our outerway and motorways. So this was like a Porsche webinar. The time flew away. And I thank everybody for his attention. I had a look, it was more than 245 participants this evening. It's a really great and amazing. And well, I say goodbye and thanks a lot. And thanks, Victor, for for being here for us today. Thanks a lot. Bye-bye.
Thank you, Jens, and the participants, of course.